Hey everybody, welcome back to another live stream on Synapse Care Solutions YouTube channel. I'm so glad you're here. If you have not met me before, my name is Kathy Randall, and I am excited to be sharing this month's series, which is Pain, Stress, and the Neonatal Brain. We're going to take a detour today and talk a little bit about parent stress in the NICU because this ultimately impacts the baby's brain development and long-term health and wellness. So in this presentation, we have Dr. Angelica Moreyra, who is sharing her work that she did while she was a postdoc fellow at Stanford with Dr. Richard Shaw, who we all know is a leader in the field of PTSD in the NICU. So in this presentation, Angelica runs through some basic definitions of PTSD. She gives some great case examples of families that she's worked with, but then the bulk of the presentation is focused on their intervention program, one that could be implemented in any NICU. One of my favorite parts of this presentation is when Angelica talks about the differences between a social worker, a psychologist, and a child life specialist. I think that sometimes we really lean hard on our social workers to do everything, and I think she does a really great job of explaining the role of the NICU psychologist and how important it is. I was just traveling last week to another NICU, and they have a NICU psychologist. So this is something that is becoming very popular and very important as we care for families and their mental health the best we can. So we know the NICU is traumatic. We know that it is stressful, but we want to create environments that are as supportive as possible. If you want to grab the notes from this presentation, some links to some articles related to PTSD and families, go ahead and scan the QR code or click the link in the show notes below and you'll get access to those right away. So I hope that you enjoy this presentation. Without further ado, I'll just bring you back to our 2019 One Conference in San Diego. I hope that you enjoy this replay and I'll see you at the end. So it is my great pleasure to introduce Dr. Angelica Moreyra. She is a clinical psychologist and she's dedicated with working and serving and supporting families. She has experience working with children and families who have experienced various forms of trauma in several different settings, including community health programs, partial hospitalization programs, and most recently, inpatient medical units such as the NICU and the PICU. Currently, Dr. Moreyra is specializing in working with perinatal mental health, infancy, and attachment and bonding issues of families that are currently or have been in the NICU. Her passion is for creating supportive, warm, and caring therapeutic environments that allows patients to face the most challenging experiences of their lives. So we want to welcome her for sharing her expertise. Angelica, please join us.
Thank you very much for having me. I'm so excited to be here. So today we're going to be talking about supporting family mental health in the NICU. So let's just get started. There we go. No disclosures to provide to you today. So let's dive in and talk about medical post-traumatic stress disorder. So I briefly want to go over some of the 4 different quadrants of PTSD as it's been updated with new DSM revisions. So exposure to traumatic events in which a person experiences, witnesses, or is confronted with events that involve actual or threatened death or serious injury or threat to physical integrity. So this can be either experienced by themselves or vicariously through another person that they're close with. So here are the 4 quadrants here. So we have re-experiencing the traumatic event. So what that might look like somebody who's having these intrusive thoughts. Intrusive thoughts are characterized by disturbing images or thoughts that might come into someone's head that they find very difficult to change focus and get those thoughts out of their mind. Other example of that could be having flashbacks or nightmares where they're replaying a traumatic event or experience that they had. You then have avoiding reminders of the traumatic event. So what that could look like is, I know that we have a lot of difficulties with parents and catching parents at bedside. And that can lead to a lot of frustration within teams saying, why isn't the parent at bedside? I can't really nail them down. And this could be a factor of that. So wanting to avoid the reminder of the traumatic event, which the NICU serves plenty of reminders to the traumatic event that they might have experienced with their infant. Then we have negative cognitions. This can be described as feelings of guilt, placing blame, feelings of anger due to the preterm delivery or to the medical team or to themselves even. Then we also have increased arousal, which is this hypervigilant arousal to medical cues or even within their own physiological symptoms. So having increased heart rate, having shortness of breath, things of that nature. I want to give you a little bit real-life example of how these 4 can work together. One way that can happen is, so let's say that you have a parent that they're getting ready to get on the elevator, and then all of a sudden they hear the ding because the elevator arrives at their floor. All of a sudden they're reminded of a time that their baby's monitor was going off because their baby was coding. So all of a sudden they're having these intrusive thoughts, these disturbing images of seeing their baby's monitor go all kind of wacko, seeing their baby turn really dusky and having some really hypervigilant response. And now they're having shortness of breath, their heart rate is pumping, they're starting to sweat, they're starting to think of all these negative cognitions of, oh, my baby's not going to make it, I did something to deserve this, I did something to cause this. And then now what happens? The next time that they want to go on an elevator, they're probably going to take the stairs because they don't want to be reminded of that experience. So that's just a real life example of how PTSD correlates to their experiences that they might be having. So now that we've kind of described it, I want to talk about PTSD in NICU parents. As you'll notice, a lot of my references are out to date. That's because there isn't as much literature on PTSD in NICU parents as one might expect. There's a lot of interest and growing interest in this area, but not a lot of publications as of this moment. We have Holditch and Davis talked about mothers, and all the sample size was only 30, so it was a pretty low sample size, but all of the parents had at least one symptom of PTSD. Then 50% had 3 symptoms of PTSD. PTSD, which I thought was fascinating, is unrelated to the medical status of the infant. So a lot of times we make assumptions that, oh, if their baby is really medically compromised or really medically fragile, one of those babies that we're not quite sure if they're going to survive, we might make the assumption that the parent is really low coping strategies, is really decompensating, is really not in a right mental state to be able to make decisions or just decompensating at bedside. However, there's a lot of research to support that's not the case. So what can happen is you could have a really relatively healthy preemie who everyone in the team is not typically concerned about, but the parents might be really decompensating. The parents might have really low coping strategies, might not have a lot of support, and they might be the families that we need to worry about. So it's not always dictated by their infant's medical status. So then, Pierre Humbert also talked about 41% of those mothers reported PTSD scores within the clinical range, and there was a relationship between maternal PTSD and sleeping and eating patterns for the infant. This is really helpful to keep in mind because a lot of times when we see these babies go home at discharge and we hope for the best for their families, they still have a lot of uphill battles to climb, right? What we want to keep in mind here is that the mother's own PTSD, her own mental health, could really be interfering with normative patterns for this infant for sleeping and eating. That could be long-lasting. Then we have Kirsting's team had a sample of 50 very low birth weight infants versus 30 controls, found that PTSD in 21% of the mothers of preterm infants versus 12% in the controls. And there was no reduction in PTSD symptoms over 14 months post-discharge. This is really important, and I think one example to really highlight this is that I was speaking at a conference in September, actually, and we had someone approach after we gave this presentation talking about PTSD in NICU parents. He was someone who had a very low birth weight preterm infant 14 years ago. He said, this really impacted me, this really stuck with me because me and my wife still have some of the symptoms that you're talking about today. This was 14 years ago. So this is not something that once they're discharged, the families go back to normal, everything stabilizes. This is something that can be very long-lasting and very disruptive for the families long after discharge. So Dr. Richard Shaw, who I worked very closely with at Stanford while I was there for my postdoctoral fellowship, had this article that he published about the relationship between acute stress disorder and PTSD in NICU parents. What they found that was really interesting is they wanted to collect data from both mothers and fathers because as we know in the NICU we have a lot more overwhelming data about mothers than we do fathers, but they equally are experiencing the same traumatic events. So what they found is they did 2 time assessments. The first time assessment was at bedside. The second time assessment was 4 months post-discharge. What they found is that, if you see here, about 55% of mothers were endorsing post-traumatic stress symptoms at bedside, whereas 4 months post-discharge, only 9% of mothers were endorsing post-traumatic stress symptoms. Then if we look at dads, their story is quite the opposite. So about, I think that's 0 or 1% of fathers at bedside were endorsing PTSD symptoms, whereas 4 months post-discharge, about 33% were endorsing symptoms. So what we see is that there's not a lack of PTSD reactions to traumatic events with fathers, it's just a delayed onset. So it seems to happen and occur later for fathers than right at bedside as it does for mothers. So parents cope differently in the NICU. Not to say that they're not having really strong responses, but it just might look a little different. Let's talk about that. So for fathers, we can have they can appear less emotionally affected, a tendency to minimize their outward emotional response. A lot of the dads seem to be the problem solvers. They want to create an action plan. How can I support my family right now? How can I support my spouse right now who seems to be really struggling? They're asking questions about, okay, what does this mean for tomorrow? What does this mean for next week? So really focusing on problem solving. Spend more energy trying to assist their spouse throughout crisis, and then tend to report less need for support in the NICU. For mothers, it tends to look a little different. So they tend to have greater levels of maternal distress outwardly, tend to have more negative assessment of the severity of the infant's problems. There's a possible role of postpartum hormonal changes. As we know, the body is never more biologically vulnerable than it is postpartum. So this could also attribute to what we see in the NICU. And then a tendency to use escapist coping mechanisms. What that means is tend to have time away from bedside. Or this is something that we faced a lot in our NICU. Wanting the team really saying, we really want to have a care conference with this family. We want to talk to them about the plan. And the parents were resistant to that, saying, I really don't want to have this care conference. I don't want to hear about the diagnosis. Can we wait? Can we wait? That's a form of escapist coping mechanisms that we more likely see with mothers than with fathers. And then also, mothers are better at mobilizing social support, better at reaching out to family, better at reaching out to friends, and better at utilizing the available support within the NICU themselves. So now that we've talked about medical PTSD and the differences in which it manifests in both mothers and fathers, let's talk about the long-term effects of PTSD on parenting. So Mills in 1998 talked about the differences that PTSD can have in the parenting long-term. So we have behavior management, so difficulties with discipline and limit setting. When do you think this might first become apparent in a parent-child dynamic? Probably around sleep training time, right? This is when we get our first glimpse into limit setting for a parent, because you don't set a lot of limits with infants. We let them run the show until we get to that point where we said, okay, we've had enough, we need to set some limits here. So difficulties with discipline and limit setting. Difficulties with connecting the child's past to their current present. So what that means is if you're trying to set a limit, you're trying to say, okay, we're going to engage in some sleep training, which is totally normal. An infant might have a little distressing response. They might say, hey, I want you to come back into my room. I'm not used to this. They might cry. What this can evoke is that the parents can then be instantly transported back into the moment when their baby was crying out of pain or distress or recovering from surgery. And then the parent can feel, oh, I'm causing my baby incredible distress or incredible pain. I can't set limits with them. I can't have them go through that. They already have been through so much. So what happens is the parents start to really not be able to manage behavior in a really appropriate normative way that children need to be able to thrive. So then disciplining may be associated with those flashbacks of the infant in the NICU as well. So that can be a real challenge for parents that have PTSD while parenting. Another example of that is maternal overprotection. So mothers are particularly protective of their infants that have been through the NICU, and then continued concerns at age 3 regarding health and physical harm, fears of violence, kidnapping, drowning, and even accidents. So what happens is these parents tend to be more overprotective of their infants. They don't let them go to play groups. They don't let them go to play dates. They don't really involve them in sports very much. They don't really involve them in other social activities. So these kids tend to be more overprotected than their peers. So then think about that in terms of their social development could look very stunted as they grow and develop. And then continued health concerns. So a wide variety of maternal concerns of health, particular difficulties during episodes of ill health, whether that's just a typical common flu or a common cold. So really struggling with those more normative childhood kind of illnesses that most kids get. And then an overuse of medical emergency services. So you see these kids ending up in the ED far likely than their peers, ending up calling their primary physicians and utilizing some help services to just get some more information about more normative health concerns. Okay, and then also this is important too, worries about speech and developmental delays. This might be really appropriate for some of our NICU graduates. However, we see whether or not there's any indication for concern for developmental delays or speech issues. These parents are coming with questions. These parents are coming with literature research about what all developmental and speech delays can look like, whether or not it's appropriate to their child's diagnosis. Okay, so then let's talk about vulnerable child syndrome. I'm wondering, just a show of hands, have people heard about vulnerable child syndrome or vulnerable baby syndrome before? A couple of you. Okay, great. Excuse me. So Green and Solnit in 1964, so quite a while ago, talked about this kind of groundbreaking idea of vulnerable child syndrome that has been expanded on today. So in vulnerable child syndrome, these are some of the things that you might see. So you might see some difficulties with separation. So babysitters are rarely utilized. And if they are babysitters utilized, 9 out of 10 times they're family. Sleep problems are common, including co-sleeping. Parents check on their child frequently during the night. One little anecdote I'd love to share with you is, as a part of our research, I met with some NICU graduate families. And I went ahead and I went to their house for dinner and talked to them about what their experience was like and what they would have found really helpful when they themselves were in the NICU so we can better serve families. And one of the families, and this mother with pride, said, I would love to show you something. So her child was now 7 years old, graduated from the NICU quite a while ago, and is thriving, doing really well. We love to hear those stories. Doing really well, and she pulls out this log. It's a big binder, and in the binder, she had logged every single feeding, she had weighed every single diaper. She had done this until her child was 2. So I think he was a relatively healthy preemie and was discharged at about 42 weeks. And from that time to 2 years old, she was keeping logs of all of these different things. This is how PTSD can be manifested in these families, that once they leave, they're still having stuck in that mindset of my baby's medically fragile, medically compromised. Difficulties with separation. Then you have infantilization, so really treating the child, no matter how old they are, as if they're still very little, very fragile and weak, needing to protect them in some way. So parents are unable to set those limits that we've talked about, and overprotective and overindulgent. So this child, when I went to their house, had really taken a run of the house. Their toys were everywhere. They were bouncing off of things. We were trying to have a conversation. He interrupted several times, which at 7 is normal. And usually one might expect that the parents would kindly set limits with the child. They let this child completely run the house. So what was happening is if he didn't want to go to school, he didn't go to school. If he didn't want to do his homework, he didn't do his homework. And the parents, it's not that they were permissive parents or they weren't good parents. They were just really still plagued by the PTSD that they had from his NICU experience. So then the child might appear disobedient, irritable, argumentative, and non-cooperative. And then also might have some feeding problems as a residual factor of that as well. Over concerns with bodily function, so more like a hypochondriacal complaints or fears causing absence from school, and then school underachievement, if you can imagine that all of these things might coalesce to include school underachievement. So the parental perception of children, and we talked about this, so I'm going to go through that. So then the prevention of postpartum traumatic stress in mothers. So now that we've talked about it, we've identified it, how it manifests, let's talk about what we can do to help these parents get through this time. At Stanford, Dr. Richard Shaw, who I worked with, had an NIMH-funded study with 100 mothers that were randomized control study. They utilized trauma-focused cognitive behavioral therapy, which we'll talk a little briefly about, to reduce parental symptoms of PTSD, anxiety, and depression. They also wanted to incorporate infant redefinition, which was focused on enhancing confidence in parenting skills, decrease perceptions of infant vulnerability, as well as reduce potential for vulnerable child syndrome. So what TFCBT is comprised of, and we'll go through this really briefly because I want to save time to talk about our intervention, is it's really about psychoeducation about the typical trauma response. So providing a lot of information to what does PTSD look like? Let's give it a name. Let's give some of your reactions to PTSD a name and call out a symptom. Then we talk about cognitive restructuring. So what's fascinating about the brain, and we know this, is the brain really likes to be organized. It likes to put things into a neat little box. It likes to say, okay, this goes here, this goes there, that makes sense. What happens with trauma is your brain is not primed to categorize traumatic experiences. It's never experienced that before. We can't prepare for it. So because of that, we start to create these really faulty associations. So an example of that is I was working with a mother once who had convinced herself that because she ate an unwashed blueberry, she had a preterm delivery. Now, this might seem laughable to some, but this mother really believed this. And that's an example of how traumatic experiences create these really faulty associations that through cognitive restructuring, we're able to break those associations. We utilize self-distracting. or thought stopping, which is telling yourself when you're having those disturbing images to really refocus on something more present focused, such as your breathing. So then we talk about relaxation training. We do exposure to the traumatic event. We desensitize the person to their own traumatic experience, and then engage in structured writing therapy. So I'm not going to go into detail about this, because this is just a quick outline of what the individual intervention looked like with Richard Shaw's study back in 2011. So this were the results. We were really excited about these results. So pro-moms for preemies, changes in trauma, depression, and anxiety. If you can see here, against the control group, there was a huge reduction of both trauma, anxiety, and depression symptoms at 4 to 5 weeks and at 6 months post-intervention. So these are really exciting results to see, and then this is why we replicated this study in a group-based forum. So why group-based? So what happened at Stanford is that they had this incredible, exciting intervention. There were not any interventions like it at the time. Very exciting, had this data, we know it works, and we don't have a NICU psychologist. So we don't have anybody to implement this intervention, so it fell flat. So this was published in 2011. I didn't start my position until 2017 there. So for 6 years, it was flat. So what we wanted to do when I came in as a postdoctoral fellow is we wanted to make a group-based TFCBT intervention that was similar to the individual intervention. So why? We wanted to do that for a multitude of reasons. One being that we wanted to reach more families. We also, a lot of the complaints that I heard from parents in the NICU, or especially from moms, that they felt isolated. They felt that no one could relate to their experience, and they felt that they just didn't have a community of people who could really understand them, and felt very socially withdrawn. So we thought, what if we get a group full of mothers, because they're all here together at the same time, what if we get them in the room and talk about what their experiences are like together? Okay, so then adapting the group manual. So we had to really get creative with this, because at the time when we were looking for role models and looking for, okay, how have other groups done this, there were only 8 other groups that had really utilized TFCBT in a group model, including a trauma narrative, and we'll talk a little bit about what that is in a second. So we said, okay, there are good news and bad news. The bad news is we don't really have much to go off of. The good news is we get to be creative. So when we were adapting the manual, we wanted to have 3 to 5 group members in each group. We wanted to keep it very intimate, very small. We really wanted to create a family-like community. We met twice a week. It was a very intensive group meeting. So we met twice a week, 1.5 hours each session. There are only 6 sessions, so it's a 3-week commitment. And in those 3 weeks, we met twice a week, so it was really intensive. The first phase, which we've completed, is 2 pilot studies, and then we got a lot of feedback from the mothers about what they felt worked, what they felt didn't work, etc. Phase 2 is the phase that we're in right now, is 100 mothers, and then compare group outcomes to historical data of individual outcomes for individual intervention, which I showed you the data for before, which is very efficacious in comparison to control groups, so we're going to compare the 2. We're collecting data from mothers at baseline, 6 weeks, and then 6 months. Okay, so before we were able to do this, I had to set up a psychological service in the NICU, because there really wasn't one at the time. So we decided to do some screening. So we were screening for anxiety, depression, and trauma symptoms. So this is how the workflow for referrals worked for us, and this is both for the group and then other individual interventions that I was providing for families as well. So they would complete the screening at the end of a 2-week period in the NICU. The reason we did a 2-week period is because we really wanted to allow for the parents to have a little time to get some sense of a routine. We didn't want to overload them right at admission where every other team is meeting with them. We wanted to give them some time. Then if they met clinical threshold for anxiety, depression, and trauma symptoms, we would then refer them by the social worker that they were assigned to for a psych consult, and an intake was scheduled within 48 hours. Okay, so let's talk about the sessions. This is what they looked like. So the first session is really focused on introducing the parents to the NICU. So the goal is to develop, we really want them to develop strong rapport with each other, with the group members, so that they feel comfortable. We have them establish group guidelines, what happens in group stays in group. We also have them write their own guidelines so that they have some ownership over the group as well. And then we provide an opportunity for them to share their observations about their babies. What do their babies look like? Or who do their babies look like? What do they know about their baby? What are their babies like? What don't their babies like? The significance of their names, those types of things. Then we talk about something we're so excited about, which is called the baby diary. The baby diary is something that we give to all of the moms that participate in our groups, and we have them, it's set up into 2 different sections. So the first section is talking about the observations that they have of their baby, so things I just mentioned, who their baby looks like, what they like, don't like. The other section is mother experiences, so the mother can really reflect on, what has my mothering experience been like in the NICU so far? What are things that I look forward to doing with you when I take you home? What are things that I've done with you that have been exciting for me while I've been here in the NICU? Those types of things. We then provide them with a visiting log. A visiting log is something that is really exciting because it provides a roadmap for parents at bedside. A lot of times the parents would say to me, I feel like I'm in the way at bedside. I feel like I don't know how to get involved. I don't know how to help. And so what this does is it just has simple tasks the parents can do at bedside. So we encourage them to consult with their bedside nurse before they engage in any of these activities, but examples of that would be kangaroo care, containing touch, swaddling, positioning, temperature, changing a diaper, talking to their baby, singing to their baby, those types of things, or even at bare minimum, asking the RN or the medical team for an update. So this gives the parents a little bit of ownership while at bedside. Okay, so this is another example of things we give to them. This is talking about multisensory stimulation, which we encourage 3 times a day, 10 minutes each time. So we separate it into things that you can do when you're with your baby, and then things that you can do in between visits, such as a scent heart, or leaving or carrying a picture of your baby, or thinking about the breast milk that you might be pumping and how it's nourishing your baby's body, those types of things. So then session 2 is cognitive restructuring. So that's really focused on disrupting those faulty associations that have been created. So the goal of this is to really empathize and normalize reactions of parents in the NICU by talking about common feelings and thoughts that other NICU parents have had. This is a great session because a lot of the moms will say, I felt really angry at myself, not being able to carry to term, and a lot of the other mothers said I felt the same way too, and that just created a nice cohesion among group members. And then we teach the mothers some techniques about cognitive restructuring, examining the evidence, what would I tell a friend, and some positive self-statements. I want to give you a very brief example of cognitive restructuring. So an activating event that you see right here is just something that happens. So you're walking down the hallway, you see a colleague, and you say hi to your colleague, and the colleague ignores you, doesn't respond. So then you have a thought or belief right here. That thought could be, oh, my colleague is mad at me, or I did something to upset them, or what a jerk. Then the feeling could be anger or sadness. And the behavior might be that the next time you see them, you ignore them. So what happens in that dynamic? Now you have a disruption in the relationship. So what we encourage the moms to do is to think about alternative reactions to that same activating event. So you can't change that. Your colleague still walks down the hallway, doesn't say hello to you, ignores you. The new thought could be maybe they're rushing to an appointment. Maybe they're having a bad day themselves. Maybe there's an emergency. The new feeling could be concern or worry. And then the new behavior could be sending a text and saying, hey, saw you rushing in the hallway, hope everything's okay. So with that example, the relationship has been repaired and strengthened as well. So this is just an example of how this can be utilized. This is really helpful when there are those contentious moments between parents and staff. This is something that the parents utilize a lot when they're really trying to create a cohesive environment among NICU staff. Then we talk about stress triggers, and self-care. We explain the physiological effects of stress. So we talk about the stress triangle, the relationship between feelings, ways of thinking, and physical sensations in the body. So when you're stressed, you tend to get tense up in your shoulders, your jaw tends to tighten, those types of things. So we teach them some relaxation techniques to help relax their body and quiet their mind and be more present focused. So then we talk about the development of the trauma narrative. So this is the one that we're most excited about. So the trauma narrative is a really helpful exercise that has the mothers do the thing that they least like to do, reflect on their experience in the NICU. So we have them, which is interesting because a lot of the moms are 24/7 thinking about their NICU experience and thinking about the delivery and thinking about all of the medical procedures their baby has had, but not really having an avenue to talk about it. So what happens is they tend to ruminate on it but have no release. So what this does is it has them talk about it and has them share it in group, actually. So in the 4th session, we have them write this, and we split it up into 3 different sections. The first section is talking about the birth experience, so reflecting on when did you first find out there was a possibility you would have a preterm delivery? How did you feel when you found out you were going to deliver early? What do you remember about the birth experience? The second section is the NICU experience. So what do you remember about the first time that you saw your baby? What was it like the first time you went to visit them in the NICU? Any medical procedures that really stood out to you or really distressing to you in the NICU? Not even for your own baby, but also in an isolette next to you, because at Stanford we had an open bay. So there were not only parents experiencing the trauma of their own infant, but seeing infants next to them that were having some difficulties or struggling. Then we have the post-traumatic impact section. This section is really helpful in reflecting on ways in which the NICU experience has impacted their understanding of themselves as parents, their partners, and then also how they see the world in response to the NICU experience. So we have them write this out in session, and then in the fifth session, we have them process the trauma narrative. So every mother walks into session 5 with a very blank look on their face. They are not excited. They are very nervous. And once they get started, and at the end of session 5, every single mother that has gone through this group has said this has been the most impactful session for them. So we have each mother share a portion of their trauma narrative, and what we do, in the way that we do that in the most fair way, is we take a look at all of the trauma narratives they wrote in session 4, and we go ahead and we look for themes across all the trauma narratives. When we were first coming up with this group manual, we were saying, how are there going to be common themes across all trauma narratives? And it turned out to be the easiest part of leading this intervention. Every single mother had very similar themes: feelings of hopelessness, fear, worry, feeling of inadequacy, anger. All of those were very present and prevalent across all the trauma narratives of the mothers. So we would go ahead and have each mother share a part that was highlighted within their narrative about each theme that we selected. And then I'm going to give you an example of this. So what we wanted to do with a trauma narrative is you want to really have the mothers transport themselves back into that moment when they were experiencing the birthing process in the delivery room, when they were having that really overwhelming care conference where they were receiving some pretty devastating news about their baby's medical status, things of that nature. You want them to think of sights, sounds, who was in the room, what were they wearing. So the exercise we have them do is we have them close their eyes, think of, who do you see? What do you smell? What do you hear? So that they really connect with that experience, so that they can have a release of emotion when discussing their trauma experience. We want them to talk about what their thoughts were at the time, what their feelings were at the time. I'm going to read you an example of a trauma narrative from one of the mothers that we had, so that you can see how vivid and detailed it is. And I invite you, if you feel comfortable, to close your eyes while listening to this and see if you can imagine what this mother's experience was like. So the prompt was, the first thing you thought when you saw your baby. I don't really remember seeing his whole body because there were so many people around him. But I said I want to see him, to the nurse in the NICU. So I sat up and I felt so many barriers between me and him, one of them being my bed. They couldn't bring him to the side of me. They brought him to the foot of the bed. Maybe they wheeled my bed around, something. No, I think I leaned forward. I must have leaned forward because my bed was in the same position. And he was at the foot of the bed and really red and translucent. I could see all his ribs, and he was so tiny. And they had the bag over his face or his mouth or his nose, and he had this plastic wrap over him. But he had his hand out. His little hand held my finger. It was such an insignificant and extremely significant moment, because what I wanted to do was hold him, which I couldn't because they had to take him to the NICU and they had to intubate him. And so it was so sweet to touch him, and it also felt really empty, because just touching a hand is so insignificant compared to the surface area of his body. Just having his tiny hand wrap around our finger, it was so significant, and in a way reminded me how little I could do for him, which I felt when they told me I had to deliver early. So go ahead and open your eyes, and you can see, you're really transported, almost like a movie, back to that moment. That's the power of the trauma narrative, because the mothers at this session, you can imagine there are a lot of tears. There's a lot of tears because they're having a release of this story they've been holding on, that they've been holding on themselves and carrying almost like a backpack that has been weighting them down, filled with bricks. And by sharing their story, it's almost like we're taking one brick out of the backpack, another brick out of the backpack, to feel this sense of release. So what's really beautiful about this is that the mothers, at the end of sharing all of their sessions, everyone's eyes are red and their noses are running and everyone's really just feeling that emotion at the end. We ask them to rate on a scale of 1 to 10 how distressed they're feeling. And a lot of times we do this at the beginning of session 2. Moms come in and they say, I'm about a 4 or 5, depending on what's happening in the NICU that day. They usually leave saying, oh, now I'm about a 6 or a 7 or an 8, and we say, that's beautiful, because you're not at a 10. You were able to share your story. You were able to talk about the most painful experience you've had in your life and walk out of this room not feeling that you're the most decompensated, most distressed you've ever felt in your life, and that's a win. A lot of the moms come in thinking, if I talk about this, I won't be able to pull it together to walk back into the NICU. I will fall apart. And we say, you are much stronger than you think you are. Look at how you've just told trauma to get in the back seat of the driver's car. You're taking control today, and you're walking out of here feeling lighter and stronger. So then we have them, in between session 5 and 6, write a letter to their baby. I would love to take credit for this idea, but I can't. This idea actually came from one of the moms that I was working with individually. She came into session one day, she said, Dr. Moreyra, I'm so excited to share this with you. I wrote a letter to my baby. She read it. It was the most beautiful, hopeful, sweetest letter that included a lot of the bits of sadness that occurred in the NICU, but also a lot of hope focused on the future. And I said, this is a great idea. We have to incorporate that into our intervention, and so here it is. So these are just some ideas of topics that mothers can talk about in their letter to their baby. Describe your baby's time in the NICU. What have you learned about them? How have they changed over time? What are some things that you look forward to doing with them in the future? What are some of the things that you hope for them in the future? So having them also reflect on who their baby is as a part of their family rather than a patient in a hospital. This is really crucial because at time for discharge, it's almost like we're saying, okay, this baby has belonged to us. Now we give them to you. We want to start this line of thinking way before discharge, because if not, it can be very overwhelming. We want that relationship, we want that bond to start right in the NICU and not wait until they're back home. So then session 6 is focused on preparing for home. So we have the mothers redefine their infant. What's great about this is it's just a 3-week commitment. So we wrap all of this up in 3 weeks, and we have the mothers reflect on where was their baby at the start of our sessions, where is their baby now, and in that 3-week span, their baby has changed miles and miles. So they're able to reflect on all of those changes that they noticed in their baby, which can be so helpful for saying, my baby is doing a lot better. They're not so translucent anymore. Their coloring is now pink, it's not red. They're able to feed that they weren't able to feed a couple weeks ago. So it's helpful for them to think about the growth that's occurred. Then we give them this really helpful pamphlet that talks about developing a successful parenting style. All of the mothers, when they read this, say, oh, can I share this with my husband? I think he needs to see this too. We encourage all of the mothers to share every bit of information that they feel they want to with their partners, with whoever they're co-parenting with, or with whatever family or support they would like to in their life. So this is, we're planting a seed here. This is because we know that mothers who have PTSD or mothers who have been through the NICU are more likely to develop vulnerable baby syndrome than any other parents. What we do is we have them think about how to develop successful parenting styles and how to be aware of unsuccessful parenting styles, such as overprotective parenting styles. So we're giving them kind of a roadmap to say, okay, I heard this somewhere, so when it's time for me to set limits, when it's time for me to go on a date or time for me to go to a wedding and I'm feeling very anxious about leaving my child with someone, I can remember that someone somewhere said something to me that this might happen, and what can I do to help with that? So now that I've talked about this, I really want to talk about the differentiation of roles in the NICU. So a lot of times what I've heard is saying, okay, our NICU doesn't have a NICU psychologist, but do we really need one? Because isn't that really what social work does? And isn't that the same? What's the difference between social work, child life, and a psychologist in the NICU setting? So we're going to briefly go over that because I think there's a really big difference in all of the roles and an importance that each role plays within the NICU. So social work. Social work, to me, is the calm amongst the storm. Social work is the only consistent provider that this family will see from start to finish. Think of how many rotating teams they see throughout their NICU experience. Rotating residents, fellows, rotating medical teams, rotating bedside, everyone changes for them. Social work is the only person that from admission to discharge, unless something happens, stays with them throughout their time there. So that's the person that's providing that regular check-in, providing that support, knows how they were feeling at the very start, knows where they're feeling in the middle, knows where they're feeling in the end. They coordinate care conferences and interdisciplinary communications with families. They connect to resources and available community support. So because they work with these families more regularly, they have a good understanding of how are they with housing, how are they with gas, how are they with food, how can we connect them to resources that they need to have a better experience here. They also advocate for families' needs. I know I see the social workers in interdisciplinary rounds, and they're the ones saying, this family would like to be transferred to a hospital closer to home. This family would like to have a different primary medical provider that they can talk to because the person that they have now is not really jiving well with this family. They're really able to provide that support and that advocacy because they work with this family so consistently. However, because they do work with each family consistently, they're assigned to every single family in the NICU. They don't have time to be able to spend dedicated hour every week with these families. So their time can look like check-ins, or if there's a family that needs additional support, they might see them every day that week for 5-10 minutes. But they don't have that ability to have that more dedicated time because they're seeing and serving every family. So then they also coordinate and support families' end-of-life care. They can be a crucial role in end-of-life, as well, which I'm sure you've experienced. Child life. Child life provides a lot of support to the siblings of infants in the NICU. That's not their only role, but that's a big role that child life plays that no other role really does. So they can read books about the NICU with the infants. They can give them some doctor kits to take home so they feel more comfortable with the equipment when they come into the NICU to visit. They can make videos. They can make recordings. They're introducing the infant or the sibling of the infant to the NICU experience, so it's not so scary when they come visit. They also create memorabilia for families to commemorate their infants' milestones like foot and handprints and things of that nature, and then can also provide support for end-of-life care, taking photographs and things like that. Now, a psychologist. So a psychologist provides in-depth psychological and therapeutic interventions at least one time a week. There are many patients that I saw twice a week, but at least once a week I'm seeing every patient for 50 minutes, typical to an outpatient setting. Because I'm not seeing every family in the NICU, I can have really dedicated time with the parents that are identified as needing that additional psychological support. I can provide diagnoses of mental health disturbances to families in the NICU. I can also connect to psychiatric referrals as needed within my talk therapy work with the parents, and I'm seeing that we're really having difficulties because mom's postpartum depression is not allowing her to shower, or she's sleeping all day, or she's not sleeping at all. Maybe we need some medication support. I can connect to psychiatric referrals as well. Provide psychoeducation to medical staff. So I've had a lot of times where the teams are saying, I'm frustrated with this parent. They're combative. They're not at bedside. And I'm saying, let's take a minute to think about mom's own mental health. Let's talk about that. I've been working with her. She has PTSD symptoms. These are manifesting in these different ways. That can be helpful to staff. Then provide support and debriefing opportunities for staff. I know that we have a lot of really hard cases, and sometimes we just need that extra support, and that's a role that a psychologist can have. They can have debriefing meetings, especially after a difficult case, things of that nature, and then can make referrals for outpatient psychotherapy as well. So while I was at my postdoc at Stanford, I was doing inpatient and outpatient support. So parents that had graduated from the NICU, I was still continuing to work with them, focusing mostly on attachment and bonding. Okay, and I'm just going to breeze through that because we don't really have time. Absolutely, and that's a fantastic question. So we don't have a therapeutic group for these mothers or intervention, but when I was doing my work in the NICU, I was working with antepartum patients in preparation for delivery and all of those different types of things. So that's another role that the NICU psychologist can play as well, but that's a great point. Thank you. I just wanted to give a thank you to our research team and collaborators, especially Richard Shaw, who I worked with very closely. My position at Stanford has ended, but I'm continuing to work on these projects because this is a passion project for me, and I will be continuing to work in the NICU at my next position at Children's Hospital of Los Angeles. So some future directions. So we're working on a fathers group. So we haven't forgotten about our fathers because it was like a wasteland for psychological interventions in the NICU. We had to start somewhere, and we chose to start with mothers. But we are working on fathers groups. We are working on a group targeting specifically vulnerable baby syndrome. We are working on universal screenings, and we have a book coming out. We're going to be publishing our work on the screenings. And then also the thing we're most excited about is creating a training program. So what our hope is to be able to go into different NICUs, create a training program, whether you have a NICU psychologist or a social work team that's really invested in this project, to be able to train and provide information on how to carry out this intervention in their own NICU. Thank you very much.
I hope that you've enjoyed this replay from our 2019 One Conference in San Diego. Thank you to Angelica for being there with us live and presenting such amazing and compelling data, and then just a path forward. I loved hearing about the future directions that she mentioned. Their book is actually available and you can order it on Amazon. I'll link that in the show notes below as well. If you haven't grabbed the slides and the other replays, go ahead and scan the QR code or click the link in the show notes below and you'll get access to those right away. If you like these videos, please do us a favor and click the like and subscribe button. It helps YouTube know to show you more videos like this, and it really helps our channel. So anyways, I hope that you're enjoying this series, and I'll see you next time.